Hello, welcome back. It is late summer in East Fife and a glorious day, just really warm. The brambles are here and they're pretty much ready. I'm walking through a stubble field, which if you live rurally, you'll know all about it. And there's just a big sense of space at the moment. Feeling quite sad about the evenings drawing in a little bit as we slowly approach autumn. But hey ho, let's hold on to these lovely days. So today, I've got a conversation that was recorded back in May of 2025 with Dr William Bird MBE. He's a GP and also a health leader who has transformed the way that we think about activity and well-being. Back in the 90s, William was one of the first people to pioneer social prescribing by creating the first health walk scheme. And then he helped create Green Gym, which we talked about with Dom Higgins, the episode before last, who's with the Wildlife Trust and worked very closely with William on Green Gym. William's a big fan of recognising that companionship and contact with nature are powerful motivators for getting moving. And since then, he's advised WHO, Sport England and the UK government and founded Intelligent Health and created Beat the Street, which is a programme that has inspired almost 2 million people to walk, wheel and cycle more. It's a fantastic intervention. I put some links into it at the end. This conversation is all about people and place and the joy of living well. So let's get into it.
How to stand on shifting sand. How to bend but stay intact.
Okay, I am here today with Dr. William Bird. Dr. Bird is someone that we want to get on the podcast from the very beginning. For my American listeners who may not recognize his name, he is, I would say, one of the most influential thinkers and really practitioners in terms of health promotion, health creation. He is a GP, but he's really been one of the leaders in reimagining medical professionals' roles in physical activity, bring physical activity to different groups and populations. So I'm really excited he's made some time to speak with us today. So Dr. Bird, thank you very much. In your own words, who are you and how did you get here?
Thank you, Andrew. Absolute pleasure to be here. So I am William Bird. I'm a GP. As said, I got here today. In fact, I'm actually in the National Trust property at the moment because I was just talking to people. So I've been working as a GP for a very, very long time. Since 1991, I started. And very quickly, and I'll explain a bit later, I realized that what I was doing wasn't really helping the patients I had with diabetes, and hence set up health walks. And then very quickly, the Green Gym. And then I kind of left general practice full time, but went to the Met Office to look at how weather affects health. So it's very much on the environmental side of things. And then moved on from that to about physical activity, about connection to nature in particular, where I joined Natural England. And then I am now doing intelligent health with Beat the Street as being one of its parts. So that's been my career. So it's always been environment and health and connecting together with the community as that kind of common denominator.
I think that's a very good overview, and I think that's one of the things that can't be stressed enough is the importance of environment and context. And both environment, as you said, when we think about things like weather and climate, and then obviously also built environment and social determinants of health. And I guess if you started in 91, that's right when Dahlgren and Whitehead really released a lot of the social determinants of health work, and we really see people adopt the socio-ecological model and really stop thinking about people as individuals, but really thinking about them in their context. So I'd like to go back in time to the mid 90s when you first started. And what I'd like to get a sense of is what was the conversation or what was the assumption of the role of the GP in terms of health, how we think about health, even how we define health. And then you said that quickly you sort of realized that perhaps a lot of what you were doing wasn't as helpful as it could be. So I'd like to talk about that time period and your experience back in the 90s and how that got you to where you are now.
Yeah, it's a really good point. And it's when you go back to the 90s, you realize how much has changed. So as a young GP, I was in a very innovative practice. So the practice had already nurses doing a lot of the clinics, which is very new then. And that was kind of just starting. But it was still the GP led the pack. The GP was there. People came to the GP with a problem. As a GP, you sorted it out and then sent them away again with either some conversation or some medication. And there wasn't that much medication as much as we have now. And it was pretty much up to your own thoughts and what you have learnt to decide it, rather than guidance and NICE guidelines and all the other guidance and protocols that we have now. But the key thing I remember very, very clearly was I was really interested in why people didn't want to do the physical activity bit when it came to the diabetes checks. Well, the other thing, of course, they ran away from is the dietitian. So they always said they had to leave early before the dietitian had it. She was a scary woman anyway, so I can understand why they would want to run away. But that was very much, the old time finger wagging, you shouldn't be eating this. And the physical activity, they kind of looked at me slightly kind of, I really should do that. And I talked to my colleagues, and at the time, the guidance was 3 times 20. So 3 times 20 minutes vigorous activity. And my colleague said, well, if they don't, they are not getting physical activity, therefore we need to land physical activity in their life. It's almost like you're anemic with iron deficiency anemia, therefore we give you iron. And that was it. It had nothing to do with their basic kind of demeanor or what they felt was good, or they had to do 3 times 20 minutes of vigorous activity. And of course, most people didn't want to do any of that. Walking, I may even remember one of the health secretaries saying that walking had no place in health because you had to get out of breath. But when I started looking at the evidence, and just at that time, Professor Hardman, had produced the first paper which really pushed about walking. And then there were a few other papers that came out at that time showing that walking had a moderate activity, but it was still a huge boulder to push up to get people to convince. But the British Heart Foundation chief medical officer did get it, and he gave me a bit of support. And the reason Health Walk started, and I think it's always important, because back in those days, I was part of the community. I lived in the community. I knew where they all lived. I knew where every diabetic lived. I could go down, and I was going for a walk on a beautiful July day. It was about 6 p.m, and with my dog, and I looked at all the patients who I knew had diabetes, and I knew that they said they couldn't exercise because it was too difficult. And I thought, hang on a sec, it's a beautiful evening. I'm going past your door. Why didn't you join me? I didn't do that. I kind of thought, what's stopping them? So I got them all into the village hall, which we had. I gave them questionnaires out, and we came up with an answer that most men didn't want to go out walking because they felt, it wasn't really helpful, but more importantly, they were worried about the styles. For those of you in the States, a stile is a kind of a thing you climb over to get over a fence, but you have to get you have to get your hip over it. And it's actually, if you've got arthritis, it's a big thing to do. And of course, they're worried that they wouldn't be able to get back home again. And they were worried about getting lost, which for men we thought was quite amusing. The women just felt unsafe, very straightforward. Hence, nobody was going out walking. So we said, what's the answer? And they said, well, look, if one of us led a walk and we had it every week at the same time, we'll all come along. And they said, yeah. So we set up 10 health walks a week. And that was in April 1996. And in April 2025, which is now, 30 years, it's still going. They're still doing better. I think they're doing about 6 to 8, and they've done it ever since. Hundreds and hundreds of volunteers have taken part. And what it did, very quickly, we realized that the physical activity was just a kind of glue that held the community and the place together. It was an activity which bound people together and bound people to their place. And that's when I realized that people connected to themselves and to the place was fundamental. So the Green Gym was conservation work, which was much more active in the actual environment. So you were making a better environment. So they changed the styles. The Green Gym went and changed the styles to make them much easier to get over with gates. They also improved the pathways, but they also did lots of conservation work. And that was about two-thirds men, one-third women. The health walks were two-thirds women, one-third men. Um, and they've been going ever since. So they're now apparently 5 million people have gone through health walks. They're now being run by the Ramblers Association and rebranded as Wellbeing Walks, but still on the same principle, same training. And all we did was say, okay, if this is going to spread out to the rest of the country, what is it you need? And we talked to a few after doing a pilot. They said, we want blanket insurance because we're worried about being sued. We want evaluation questions which we can benchmark ourselves against other people. We want to have a marketing brand where we can all sit underneath it, but we'll all have our own names. We want to have qualified training, and we want to have quality kite mark to show that we've done all the things that we should do. So that's all we provided. So all these walking groups could now affiliate themselves to the Health Walk program, and they kept their own identity, they kept their own way, but the quality was good, which meant the NHS was confident to be able to refer patients into it. And that was really social prescribing back in the 1990s.
You made a lot of good points there, and I just wrote down a few notes, and I guess I would just like to go back to some of the points you brought up, which is obviously the narrative that people have about themselves and the physical activity they can engage with. And one of the things you said is a lot of people said, "Oh, I can't exercise. I don't exercise." But then obviously, given the right context and support, people could engage in walking. And there was that debate over whether or not walking was enough. But I think, especially if you think about diabetes and, the sort of discussion over whether or not the exercise needs to be rigorous or vigorous, or whether or not you can just have a nice time while you're doing it, do you think that the framing of physical activity as exercise, do you think that is often detrimental? I mean, just that we assume most physical activity and movement needs to come in the form of exercise?
Yeah, I think we still haven't got it right. Um, I think there's a long way to go. I mean, look at the figures. I mean, just they speak for themselves. And I was kind of slightly amused when public health people say, "Oh, we only do evidence-based medicine about promoting public health." And I say, "Well, what evidence have you got that anything's changed for the
Yeah,
last 10 years?"
exactly.
Because it hasn't. So clearly, that evidence-based medicine isn't evidence-based. It may be published, but it may be one study done somewhere. But we've got to be brave, and we've got to think, what is it that's going wrong? And increasingly, and there is some neuroscience behind it to back it up. But when you get chronically stressed and you're worried, so if you're in a third floor flat with 3 kids and you're worried about where the money, the food, the crime around you, the kids being on their phones, all the things that you'd be absolutely kind of affecting your mind, you're chronically stressed. You are waking up in the morning with a palpitation, your body has shifted, your cortisol is coming through. But the other stress hormone people forget is ghrelin. Now, ghrelin actually increases your appetite and helps you to eat because it's obviously counteracting starvation, which would have been in hunter-gatherer times the main cause of stress. And every animal in the animal kingdom, calories and energy is fundamental. But the other thing it does is quite makes sense is it stops you from exercising. It stops you having that desire, and that's been found quite recently. So the ghrelin affects the hypothalamus to actually stop you having any need to want to exercise. It does the opposite to what you expect, and that makes sense because if you're doing unnecessary exercise, you're burning unnecessary calories in a time of stress when calories are in short supply. So it's not surprising that when you tell someone to exercise and they're in a bad place, they're never going to do it, and they're not going to lose weight either.
We always see this blowback effect as well. If someone is in this sort of state where they have a sort of thrifty metabolism, you'll find that even if they consciously increase their physical activity on one end, then they'll reduce it on the other end. So, okay, well, I've gone for a run this morning, but they'll be more likely to sit on the couch later. Which is why I think the calories in, calories out, eat less, exercise model is always, it's bound to fail. And you drew a good distinction there. I don't know if it's a distinction that you use, but sometimes in public health, people will talk about the difference between efficacy and effectiveness. And efficacy is obviously something that works well in a clinical setting, like in a metabolic ward, whereas effectiveness is, does it work in the real world? And I think we do see this big disconnect, and as you said, there's so much emphasis on evidence-based practice, but obviously sometimes the quality of evidence isn't great, and we often ignore the practice-based evidence. of this sort of wisdom. There's another distinction I like, which is used sometimes in philosophy of metis versus technon, which is the difference between book learning and learning that you can only get through actually doing something. And I think sometimes we're missing too much of that physical sort of tacit learning, because we spend so much time looking for a paper that would just validate whatever it is that we want to do.
I totally agree, and I think you kind of summed it up really well, and the efficacy and and effectiveness, and that is one of the problems where we have gone into evidence-based medicine. It stops innovation often, and stops bravery as well. It stops people being bold and saying, "Look, I'm gonna do something new."
I was going to talk about this later in the conversation, but since we're on it anyway, and you've talked about this in the past as well, is I've seen so many interesting programs and so many interesting, I don't know if I'd call them interventions, but maybe local community assets, local community programs that obviously work. You can sort of use common sense and say they're getting people out, they're getting people moving, it's creating the sense of community. But the burden of trying to create metrics or data to show that this is useful, to show that this is something that is worth getting funding from, is often so onerous that you never see these interventions, these programs scale up, because it's just too hard to have the numbers to say that something works, even though it's quite obvious that at least this implementation in this context works very well.
Yeah, and you always think about, look at all the parks in London, all built in about the late 19th century. Nobody did a randomized controlled trial to see if they were going to be the best way of doing it. It just said common sense. Let's build a park. It's good for you. Oh, that's funny enough, it is. And we tie ourselves up in knots now. Yes, of course, you need evidence-based medicine when you've got something that's going to harm you, and or you're going to put a lot of money into it. Um, but there's still common sense, as you say. Just kind of, yeah, I kind of moved because the bit you did mention about have we framed it right in the physical activity, and I think no is the answer, because I think physical activity is an outcome of a fulfilled, balanced, hopeful community, and I think it almost comes out naturally. And in fact, I think you could go into a community and not mention anything about physical activity at all, and just make them much more connected to themselves and to the place around them by doing events or volunteer works and getting them out. And you'd notice those physical activity levels would come up because their stress levels have dropped. They've got that communal aspect. They've got purpose in now going outdoors and meeting each other. And we focus too much on the physical activity interventions. The WHO, I can't remember if it's 8 or 9, areas where we should be focusing on. I get it. Yeah, totally. We want to introduce it into NHS, speak, or healthcare speak, in the US. But if we do this in these parameters, you're still adding physical activity onto people's lives. And I think we need to get them feeling good about themselves, and physical activity will come out. That doesn't mean we don't do anything about physical activity, because we need to have the opportunities. We need to make sure that the places to walk are safe. We need to make sure the parks have got some really good access and people don't feel dangerous, or they feel safe in them. So we have to have all the infrastructure around it, but you then have to activate the community to use that infrastructure. Build it and they won't come. And we've got so much evidence in what we've been doing.
That's really interesting across the board. One of the comments you made earlier when we were talking about when you were first getting people moving is how physical activity is such a great connection. I think we do miss a trick sometimes, where when we think of physical activity as being something you go to the gym, you put your headphones on, and then you run on the treadmill for an hour or whatever. It's such a missed opportunity to make these cross connections. And it's funny. I often think about Reading, because Reading, quite classically, there's a lot of post-war urban planning around Reading, and famously Reading has sort of motorways and things going through it. And I think in America, I don't know if you've ever read Jane Jacobs, but she used to do these beautiful maps of these cities, and you could see how many cross connections there were in a neighborhood. And then the moment you put a giant motorway or you made it inaccessible by walking, you would just see that the number of these connections would just disappear, and everything else falls apart when you don't have these opportunities to see your neighbors. Um, so it's interesting what you said about if you build it, they won't come sometimes. And I was wondering, can you think of a few specific examples of maybe investing some money into infrastructure or green space where for whatever reason it didn't work, and then maybe if we found some solutions after that?
I can give you a really good example, because I remember to this day the reaction of the council when they the data was about to be published in a big ceremony in northeast Belfast. It was, and they got a lot of EU money to make up what was a really deprived area, pretty desolate. There was a canal that ran through it and a river, and where they merged, there was flooding, and it was just loads of bedsteads and shopping trolleys in it, and it was not really safe to walk along that canal at all. It was just a load of desolate ground as well. So they brought in money, they straightened the river to stop it from flooding. They improved and made lawns and grass and got footpaths, and they brought the community who were there living there on board, some community representatives. And then when he looked at it, it was phenomenal. It was really lovely, and it was about 50, 60 million it cost them to do that. So it was a major infrastructure project in northeast Belfast. And the researchers at Queen's University had done it before to every household about physical activity, where they go, etc. And then they did it after a year, settled in, etc. And physical activity levels had gone down in the neighbourhood. And they thought, oh my God, what have we done? Help. And they were scratching their heads, and we launched it. And, you can only massage the figures enough, or massage the story enough.
Oh, what a horrible feeling.
And they were standing there, just head in their hands, thinking,
Yeah.
we just created this amazing £60 million for this deprived community to get more active. But the numbers of people using it were massive. Of course, they weren't local. They were all people who come in. And what had happened is, yes, they had included some of the community, and I think this is always a good example, but they'd consulted the community rather than had a conversation with the community. And when you started to have the conversations, which they did retrospectively, there was a couple of kind of bedsteads in the thing sticking up. But there was folklore about how Aunt Betty got drunk one night, and those bedsteads were part of the kind of culture of that place. They were part of the heritage. Everyone else saw them as just a bit of junk in the canal that had to be taken up. And there were loads of examples where they'd taken even some of the graffiti, I think, had sort of a certain thing. So we hadn't really had a conversation with the community to say, how would you fit with you? What would you really like? They just got a few representatives and then consulted with them. And that's one of my big things. Consultation and conversation are very different things. Consultation has a power base. When I was a GP, which I still am, talk to my patient as a consultation, I'm leading the charge. I'm in charge. I've got power over you, and I'm framing our conversation, and you have to fit into my framing because I've been taught how to do a good consultation. So you miss things. You miss loads of things. Having a conversation is equal power. You share it. And there's no structure, so you meander, and you meander where the energy is and where the people are wanting to do it. And you also give enough time for people to get confidence to tell them about things, whereas if it's rigidly consulted, you never get to that point. And I think what they realize, this is, we can call it gentrification, which it was in a way, but it never had that real kind of understanding of what the community felt. What was their heritage? What was their culture? What was their rootedness that kept them there? And that had all been swept away when they did this renovation. So they didn't want to go out. And then, of course, all these people, strangers from other parts of Belfast, thought this is a lovely place to go for a picnic and take my children. So they lost their identity completely of that place. And I think that's one of the things we have to do, is understand that as soon as you disconnect from your place, you stay indoors and you become less active. And that's exactly what happened to this community.
It's interesting. It makes me think of a case studies we see in anthropology sometimes. And anthropologists will make this distinction between emic, phonemic, the meaning of a place, and etic, phonetic, like the outside observer's interpretation. And one of the cases you see quite a lot is when in Central Africa or Western Africa or sub-Saharan Africa, when organizations will come in and they'll drill the wells so that the women in the village no longer have to walk out to the river. And then quite often you see that a few months later, the women have stopped using the wells in the village because there's so much cultural value in taking those few hours of walking out to the river, catching up on gossip, talking to people, getting away from your husbands, having some time to chat. So for an outsider, people say, well, isn't it horrible that these women have to walk so far to the river, which is true. It's an onerous task. but we completely ignore all the other hard to quantify values that we get from that. Um, I would like to talk a little bit about the distinction between place versus space, or maybe place versus venue. It's a distinction I don't see a lot in the States, in America, but it's something that I think we've done a very good job of talking about in the UK, about either the importance of place and venue, as a distinction. Because I think sometimes it's really important to talk about what do we mean when we talk about place-based interventions or place-based programs. Could you talk about that?
Yeah, and it is increasing. I think we're still learning a lot. From that example you said, and other things where we know people's connection. And when we're looking at the health creation matrix, which I'll explain a bit later on, you look at place. There's obviously the safety, but there are two other parts of feeling valued in that place, and that's a resonance where you actually resonate with the place. So it doesn't have to be nature, but nature is a good place. But it's heritage. It was at Bedstead, and you kind of feel you are emboldened, and you're even got you got more value by being in that place, by not being in that place. And I think that place there is this person who can sit down on a bench looking out and feel, yes, they belong, and belonging is an important thing and a rootedness, but they also feel increasingly valued by just being there. And I think there are two parts to it. One of them is that you've got nature, which is bigger than you, or you've got heritage, which is stretches back for hundreds of years. So you're a small little part of that bigger picture of the world. And I think that gives us that kind of, in a way, a real sense of a bit more of identity, that we actually do belong here. We've got a right to be here. Um, but the other thing is that it also then connects with the people in the community, etc., as well. So the humanity that's come to that place has helped shape it and change it. So that nature on its own can sometimes be quite scary. You go to a wild place, and it's actually not very. You don't kind of resonate. You kind of can feel quite scared, and some people feel scared just in a park, which has been beautifully done for biodiversity, but they don't feel actually they resonate. They prefer a much more manicured. So we all have a very separate connection to the place. We have a separate connection to nature. And I think what we kind of have to work out is every single person will be very different. Some people will love the wilds and the mountains and being outdoors in a, kind of doing outward bound type of things. Others just walking down into, or sitting on the barbecue in the garden, or just perhaps going to a barbecue in the park, but not far from the car, is that first step. And both are right. Both are fine, but we have to judge. We don't value. We kind of judge people, saying, "God, how awful! They haven't even gone out of their car. What they should be doing is having proper nature." So we put these metrics, we put these judgment values on people's relationship to their place, and we expect everyone to fall into our criteria. And if we're environmentalists, basically we hate anyone coming into our place. So we can judge people, and of course then they don't do it, and then we've got no ball signs, no keep off the grass, do that. So everything is screaming at them, don't come here because we don't want you, we're not valued. um, so I think from a place point of view, it is absolutely critical. You cannot have a strong community without having a strong community connected to place. You can't have a strong place without having a community. The two are utterly welded together.
Yeah, that makes a lot of sense. And I think in a second it would be good to talk about the health creation index or the matrix, because I think it's a very important tool. It might be hard to explain verbally over the podcast, but I'll make sure that I send a link so people can see the graphic. What you were saying about being valued and sense of value is really interesting, because obviously that's bidirectional as well. And one of the things I've found so much, when working, not even just with volunteers, but in working in physical activity, and even at a gym, an exercise setting, as I did in the past, there's such a big difference between swooping in and feeling you're providing a service for people versus giving a space where people, they themselves can feel valued. So moving away from that sort of neoliberal transaction idea of turning everything into a monetary transaction, and actually trying to create spaces for mutual aid or reciprocity. And I found that one of the most important things for sustainability is if people themselves feel like they have something to offer, that they have something to contribute. So not just a service providing something for people, but giving them an opportunity to get those cross connections. And it's one of those things that often we see that there's so rarely an opportunity, say working in a commercial gym, where people feel like they can provide anything but money. And I think that's a real tragic lost opportunity.
I agree, and I think we have to let go. We have to know when we just need to let go and just let people be. I actually remember going back to the 1990s, and those in the States will know the big tome that came out, the ACEM. I think it's the American College of Exercise Medicine. I think it's
Yeah, there's the American College of Sports Medicine, ACSM.
ACSM. Yeah,
ACSM,
and it
that's
was
right.
this big book, and some listeners will remember it, which went through every single disease, and it had a formula and it had a prescription of physical activity for that specific disease. I mean, it was huge. I remember buying it; it cost a fortune, and I
I've got
used
a
to
copy,
pore
yeah.
through it and think, "Oh wow, this is amazing! This is actually, if someone's got rheumatoid arthritis, this is a prescription." And of course, it makes no relative understanding of the person where they're coming from. And of course, that has now been superseded and it's gone. So we have moved, which is quite reassuring. We also had hundreds of contraindications um, and worries about people. And you had to have this great long list. Hardly anyone ever qualified for it because you had to have a cardiologist at hand the whole time to do anything. And of course, that's been swept away now. So I think we have made progress on that. But as you say, we've still got this thing that we've got to intervene. We've got to, be the hero to that person, rather than just on an equal status, equal power, that you let them do what they know is best for them. And perhaps you give a little bit of guidance, a touching, but encouragement.
I'd really like to stay on that topic because I wasn't gonna bring it up. I hadn't thought about it, but I think the ACSM and this sort of period in physical activity where everything was contraindicated and essentially you needed this big decision tree, like if you were going to work with somebody, first off, have they gotten checked off by their GP, have they talked to their physio, have they talked to their dietitian, so on and so forth. Do they have rheumatoid or arthritis? If so, don't do this movement. If their whatever their bone density is below this, don't do this. And obviously it comes from a very, very good place,
Hmm.
but also America, it also comes from a fear of litigation, because obviously America is a much more litigious society, perhaps because they don't have nationalized healthcare. Um, but actually, what you brought up, it did make me think, because you did reference it as well at the beginning of the health walks, is this idea of risk, this idea of liability, and how we talk about risk and engaging in physical activity. And I think the conversation has improved a lot. But I was wondering if you could kind of talk about where we are with this idea of risk, and sort of like aversion in society right now.
So I think there are two aspects of risk. One we've kind of just mentioned, and I think that is often a justification of a professional to have a role, because if you have risk, then it means I can therefore allay the fear of that patient, but only I can do it because I'm a professional. So there's a bit of that aspect of why risk is so hard to kind of eliminate. As you say, litigation is clearly a big thing. It's got better. I mean, we've done health walks for now 30 years. 5 million people have gone through it. If you multiply that by the number of walks, that's a lot of walks. I think we've had no, not a single claim on insurance.
Hmm. Wow.
So the risk is minute when you look at it like that. The other risk is perception from the patient of risk, as opposed to the professional imposing that risk on that patient. And when you have a perception, I would say, and it kind of mixes in with trust and feeling of safety. And all of those are about chronic stress. So if you're chronically stressed and you've got adrenaline, noradrenaline, and cortisol floating around, your brain will be shifting towards not trusting people and also seeing danger everywhere, because that's how your brain is protecting you. It's doing exactly what it's meant to do. It's not doing anything unusual. It's saying, right, you've got a heightened state of awareness. You don't know what it is that's in danger, but it could be paying the bills. It could be, but it means you look at every other person. You look at all around you. So we've done some evidence and showed some work in Trafford in Manchester, where it's a really lovely park there. And we asked the people living on one road what they felt about that place and whether it's a good place, a safe place to walk. And we found that pretty much half the people said it was a really safe place and they liked it, and the other half said no, it was unsafe and we wouldn't go there. And we kind of was the same street, same park. So we then did the health creation. And I won't quite go onto that yet, but we then looked, and those people were stressed. They didn't trust anyone around. Those people that felt the park was unsafe. So their view of that park was unrealistic because the park actually was safe, but they saw it as risk, and therefore they wouldn't want to go out and exercise. They wouldn't want to take their children there. And what we have to remember is that people see the world in a very different way when they have this chronic stress compared to someone who's feeling quite okay about themselves. And a lot of that goes back to childhood, how they're grown up. But I think it opened my eyes to realize that you can change infrastructure as much as you like, unless you get people out there and connected and make it really safe for them, but having other people they trust around there, then they will only see everything as a risk. And I think that's the other aspect. And if you've got a long-term condition and you've been told to go for a walk and you've got diabetes, etc., you're going to see things because you're a bit worried. You're going to see risks there, and you do need to be reassured. And I think we just have to just take it to the patient that walking is pretty much zero risk on every front. Start there. But you don't need to go to the gym and do the big kind of stretch exercises or other things like that. Just start with that walking, and then pretty much everyone is going to be okay.
And it's such a good way to get your foot in the door because it does start changing narratives. It's interesting what you were saying about the stress. And I've sort of heard similar narratives from Robert Sapolsky, and Michael Marmot sort of talks about this as well, and just how all encompassing this chronic stress can be on people. And as you were talking, it was interesting. It reminded me of some of Peter O'Sullivan's work, and he does cognitive functional therapy for lower back pain, which is being adopted across the NHS. I don't know if you've
No.
come across this. It's really interesting. It's the way that we talk about pain and how complex pain is, and obviously, pain has this biopsychosocial component to it, which is our perception of pain and danger is dynamic based on our stress levels. And if people are stressed, then their body will become hypersensitive to pain, specifically lower back pain, which is so complex, and sciatica and things like that. Stress is almost a better predictor than mechanical or structural damage in how people perceive back pain. It's really interesting because a lot of this cognitive functional training is specifically getting people to let their guard down and to kind of open up and lose that hypervigilant stance. And then we see that it has all these powerful feedback effects in terms of perception of pain, perception of risk, fear of falling cycle, fear of pain avoidance cycles, isolation, and things like that. So what you're saying really it really resonates with me because it's one of these things that you see works at so many different levels. It works at the individual level and obviously at the community level as well.
And actually, just so one of the things that, when I mentioned about that when you got chronic stress, you look at people and don't trust them as well, and you talk about the pain there. It's very important for everyone to understand that acute stress is absolutely fine. Acute stress is very normal. Actually, it's motivating. It actually keeps us on our toes. It can be hugely satisfying when we've gone through an acute stress and we've come out the other side. It will give us more confidence. So everything about acute stress is good. Um, Even though it
As
may
long
be
as
a bit
it's acute.
uncomfortable. The
Yeah.
chronic, even the chemicals change. So cortisol in acute stress is an anti-inflammatory. Cortisol in chronic stress is an inflammatory. So it's not just the wording that changes, the biology and the physiology changes. And what we have to remember is that chronic stress is, I think, pretty much the foundation of most of the health problems we have in this world now. It leads to the chronic inflammation, mitochondrial dysfunction, all the way down to the disease level. But it's something which has become inherent, and there are lots of reasons we can talk about another time on why we're so chronically stressed, but it is physiologically very, very different.
Yeah, I'm really glad you brought that out because it's very easy to fall into this narrative of cortisol being a bad hormone. Um, where like you said, it's completely dependent on the context of it being anti-inflammatory corticosteroids and things like that. And I think that's really important to bring up when we do start talking about endocrinology and things like that because it is complex. It is context specific, and I'm glad that you mentioned that. I think that we should go ahead and talk about the matrix now. The health creation. index, because I think it's a really powerful tool, and I'll make sure I can go ahead and get an image for people. But if you could just sort of describe it, the setup of it and how that informs your thinking when you think about creating some sort of intervention or program.
I mean, it came about because I think at the moment we talk about treatment. Okay, everyone knows what treatment is, and then we talk about prevention. But prevention is in many, many layers, and we've thrown everything into prevention. Now, the thing about prevention, the measurement of prevention is an absence of certain diseases or cost savings to the NHS. In other words, we're wrapping our entire well-being and health in a country around not having diseases or living a little bit longer. But there's no destination. It's a negative thing. So if you got all of that right and you got rid of all your diseases, you're left with zero. So you still haven't got anywhere. So in a way, we're constantly running away from disease, which is why I think part of it creates stress, because I mustn't eat that, I must do that, I mustn't do that. Oh, I'm smoke. Oh gosh, I had some chocolate the other day. Should I have that? Should it have been dark chocolate, or should it have been? We've gone crazy in worrying about, because we're measuring it against. You will get diabetes, you will get obesity, you will get. So it's a very negative. So it's like, I think it is in oh god, I can't remember which film it is, where you've got the headless horseman chasing you, and they are constantly chasing you, and it's like this death and diabetes and despair and mental health problems and arthritis. Everyone's saying they're chasing you. You've got to keep up with your health prevention. But where am I going to? It doesn't matter. Just keep running, because you don't want them to catch up. That's not a world most people want to live in. Most people want to live in a world where it's a really good place to bring up children. They feel really content with their life. They enjoy it. They've got good friends around them. They've got purpose. They've got meaning. And we kind of feel that as a bit soft and fluffy. But actually, when you look at the science behind it, and we know from longitudinal studies that Harvard did it's people, it's the connections we have. And that connection to nature, we now know, is incredibly powerful in being a place, more so than anything else. Finally, that's a destination. That's where you want to go to. And if you go there, you then get buffered from all those other stressful things. So the chronic stress disappears. And therefore, automatically, your body shifts to wanting to eat better, to be more active, as we've already discussed about ghrelin. And you don't have to think about health. And that would be the ultimate aim of this, is that you no longer have to think about disease or health. You just do. You just a good life. And the health creation matrix was a way of measuring that third element, which goes beyond prevention. So of course we have vaccinations. Of course we do things like screening and other ways in treating people's blood pressure. That's an important part of prevention. But to tell people everything is about prevention means that we're going against what WHO said right when it was formed in 1947, that health is not simply the absence of disease. It's in there, black and white, and we kind of have forgotten it. So what the way of measuring it is that you have 3 rows. Those rows are to feel safe, to feel valued, and to feel you belong. They're pretty much neuroscience. Pretty much every animal, and certainly every mammal, will have those 3 as absolutely critical, with safety being number 1. But humans, particularly the belonging bit. And then you've got the 3 domains of your life: the people around you on one side, the place around you on the other side, and down the middle is your purpose of why you're here. And then you can fill the 9 squares in between with certain things. So just as an example, the safety and people is about trust. That is what is the best way of feeling safe, or love. And we can start even using that word of love and compassion. And if you go to the people, and then you go to valued, that's about respect, about listening, about empathy. So you can fill these, and you can see how, as a leader, you would want your organization to have those attributes all around to help keep the pillars intact of health in your organization. But as an individual, you can also say, I need to have that connection with my dearest. I need to keep my friends. I need to have more giving and feeling more valued, which is on the the bottom middle. I need to have connection to my place. I've got to keep away from the psychological where I don't feel safe. So all these things can be looked at. And of course, as a child, it's even more important because if a child, as we know, doesn't feel safe in its upbringing, that's going to have an impact on the rest of their life through their hypervigilant status. But this gives a measure. We've actually designed 9 questions. In fact, we had 10 because we have optimism or hope and control of your life as 2 in one box. So we have those 10 questions. We've sent it out to 75,000 people through our game Beat the Street. And then we've mapped it down to street level. And then we've superimposed physical activity levels, well-being levels, even health levels as well. And it's pretty much a perfect match. And the one question that completely differentiates the more deprived communities from the affluent is not friends. They've got lots of friends. They love their friends. It's not hope. They're actually quite hopeful, despite what most people think. They've even got more control than I would have thought, but they hate the place they live in. So when we ask, is this a good place to bring up children? Absolutely not. This is a terrible place to bring up children. But the affluent places will say this is a brilliant place to bring up children. And that is a sense of safety, basically. That's looking at a place to think, my child wouldn't be safe in this place. And I think by doing this, we can now look at the positives of where you want a place to be. Because in the end, and I've just been on a discussion where we've talked about nature, but the people talking about transport are achieving the same thing. The people talking about growth and economy, they want the best people to live there. In fact, we're all asking for the same thing. It's just we want to have a good life. I just want to enjoy our life. It's really simple. And we've layered it with all these kind of disease prevention and cost effectiveness, which makes people into a unit of volume of a kind of a resource that we can't afford anymore. And it makes it incredibly negative. Whereas obviously the asset-based community development is where we're heading, which is of course being proposed by many people, including Cormac Russell, who I've got a huge amount of time for. So that's what the matrix does. And by measuring a place, it allows you to understand, A, where the problems are, but also those are all sortable. So with Michael Marmot doing his work, which is absolutely fantastic, but they're big chunky things like you've got to change the education system. You've got to get all those parks sorted out. And everyone thinks, oh my goodness, how am I going to afford that? Well, I've got to get new jobs into this area. They're pretty difficult things to kind of shift. But you can get more trust in a place. You can get more connections with the place. You can get more events going on to get people more connected. So actually with the health matrix and health creation is definitely not my idea. It's been around for a long time, and it's been proposed by many people as a health creation alliance. It's going 10 years, and they've been promoting it. But that is something that's all doable, and you can change it really quickly. And I'll talk about Beat the Street, but just now I'll say that when we get a lot of people out walking and talking to each other, and we measure their trust before and after, it shifts by about 15 to 20% without us having to do anything at all, because they're now seeing people as not enemies. They're seeing people that they can actually connect with. And the place is no longer a dangerous place because they're out there with other people. And therefore their stress levels come. And oxytocin, which helps trust, goes up hugely in acute stress, which is why we all hug each other in a crisis, but it then absolutely plummets when it's chronic stress. So it's a very good proxy measure. Trust is a good proxy measure of whether someone's stressed or a community has got chronic stress or not.
That makes sense. You covered a lot, but I think that actually, if we did go ahead and talk about Beat the Street now, and the genesis of Beat the Street and sort of some of the ethos behind it and the problems you're trying to solve, I think it'd be good to explain. I think it'd be really helpful to talk about the start of Beat the Street, the why of Beat the Street, and maybe also talk about some of the weekly themes that come out throughout the course of Beat the Street, because I think a lot of my American listeners might not know it, and it's such a fantastic program. I think it'd be great to spend some time explaining it.
Well, it came after I was at Natural England, so I was working for the environment part of the government, and I kind of felt that we were, with academia and public sector, things don't move very quickly. They get a bit frustrating, as anyone who works in both of them will probably kind of completely understand. So I set up my own company, which I had no clue what I was doing. I had no idea. I even ticked the wrong box on. So it's a for-profit company. It wasn't meant to be, but I ticked the box anyway. So there it is. And the idea was to actually help both train GPs about physical activity, but it was also to do a game where I could get schools more active. So we invented Beat the Street. I had little Nokia phones inside wooden boxes. And if everyone remembers those Nokia phones, bricks with the NFC attached to it. And then I got Lancaster University to do some kind of clever stuff. And we set these when they needed charging every single day. It was an absolute nightmare. But it proved the point, it worked. And we moved it from schools to then decided, actually, why don't we do the whole community? Why don't we get the mums and dads and everyone else involved? And believe it or not, we suddenly got 10% of the population engaged. Couldn't believe it. That was the first time we did it in Reading. It was in Caversham. And then we thought, well, hang on a sec, it's amazing now because we're now getting them all engaged. Let's get community groups, etc., and workplaces. So we've gone up to sometimes, I think the highest is 32% of the population have played, 1 in 3 of every man, woman, and child in some of the populations. And the reason it happens is because we set up beat boxes, little RFID readers, which are no longer, you'll be pleased to know, Nokia phones in wooden boxes, a little bit more sophisticated. And we have to get permission for every single one because they're in public land and lampposts. And we work with the council to know, where do you want people to go to? And they say, well, we'd love them to use this cycleway, which nobody uses. We'd love them to go to this park because nobody goes there, or the museum, or we want them to go and visit some of our heritage that we've got. So we set these beat boxes, sometimes 50, 100, sometimes 300 in big places. And then we give every single child the card. And you might think, wow, how do you do that? And we go to the schools and we get 100% of schools, almost every single time, 100% of schools engage. And we've learnt how to get them on board. They give a pack out. We give them a pack. There's a card for every child. They take that pack home and they give it to their mum and dad. And then community groups come on, workplaces come on, from libraries, from shopping centres. We have these cards, and they're small RFID cards. You'll be pleased to know that they are biodegradable. And then they go out and all they have to do is to tap that card from one beat box to another. There's no entry point, which makes it hard. So we pull it into the most deprived communities. So they see the beat box in that deprived community. And then the magic happens by having a leaderboard and having teams. And there's some pictures out in Barnsley because there are 22,000 people playing in Barnsley at this moment. We got the minister down actually yesterday because it's our 2 millionth player has just come through. But what you see at the end is physical activity levels increased by about 8 to 10% on average. And we've had about 200,000 people we've measured before and afters. We've got a massive database. And it's pretty consistent. And we know that even 2 years later, when we follow them up, it maintains itself. And what we've done is that we've created a platform. And just as you said earlier on, it creates a platform for people to do their own thing. So the communities take on this and say, well, why don't we set up a walking group? Why don't we set up this? I didn't know nobody had gone to this park before, so we need to start looking up. And all the community groups that are already active then become turbocharged because they've recruited so many more people. So we don't want that game to last long. We kill it at 6 weeks. And we make sure that it's not so addictive that they will actually miss it and therefore go back to zero. The delicate balance we've taken 12 years to perfect is that you want a game that attracts lots and lots of people. And just as a comparison, we actually overrepresent from Pokemon Go. So we get more people than Pokemon Go did in a place. Pokemon Go did it brilliantly globally and nationally, but it got about 10% in a place. And we're getting 12 to 14% on average now. So everyone represents but Pokemon Go. But what we do then is we pull them away from the game so that the parent taking their child on a bike to a park to get points or walking a funny way around to get to school in the mornings, they stay, they remain because suddenly the parent thinks it's a lot quicker to walk than go by car. I'm talking to my child, I'm enjoying it, but it needed a catalyst, it needed something to get me going. And that's what it is. It's an energizer, it's a catalyst that, because so many people are engaged, changes the town's view about what it's got. But then we want it to stop. So you can think about all the Octalis ways of getting people addicted to a game. And our IT director would love to have all these gizmos and gadgets of keeping people and taking things away and having fun. But we don't want people to be, we want them to come in, but we want them to come out and then continue their work. So we are that engine.
It's really interesting. And it's interesting what you said about it being a catalyst and just, creating these opportunities for interaction, and the fact that it has a legacy, which I think is one of the concerns about any sort of program that lasts a finite amount of time. People always wonder what comes next. So you alluded to it already, but I was wondering, could you talk about some of the things that have come out of this catalytic process, like maybe some communities who, once the beat the street is over, what they've done with that energy?
Yeah, so I'll take an example of Burnley. So Burnley is a industrial town, ex-industrial town in the north, very deprived area. Although it's got some pockets of absolute brilliance, and they've just finished Beat Street for the third time in 6 years. And what it did was they had no idea the impact it would have because so many people were doing it. And there was a big call for the council to do something as a follow up, and they wanted to make it an outdoor town. So they've created this outdoor town, and by having it as an outdoor town, it means everything they do in that place. And we managed to get trees for points. So every time we got 100,000 points, they got a tree, and that was planted. But the whole council now, from a leader of the council, now talk about an outdoor town being fundamental. It wasn't about biodiversity. It wasn't about net zero. It wasn't about all the worthy things or kind of cutting out um, carbon from people driving. It was about you doing stuff with your family in a place that we're proud of because of the heritage of the mill town. And by having that positive feel about it, people felt this is a brilliant way of doing it. So when they did Beat Street the second time, they got all the community groups who were doing that to energize themselves by getting more people into it. And this third one has now consolidated that. And Burnley really is now very much an outdoor town. All the small organizations and community groups that are doing conservation work or others who are struggling for finance, they've now got a label they can put, we're part of the outdoor town, and they get council to kind of connect with them. So it was Beat Street was a catalyst to change the philosophy and the strategy of the place, and it has made a massive difference. And you see that in lots of other places. In Dudley, it helped them put where the new extension of the metro went. Um, in other areas, it's helped the museums and other places to come to life, the libraries to come to life. It's helped thousands, and we can say thousands of small community groups have evolved out of Beat the Street because they all started during it because people wanted to continue afterwards and not let it all die. So that's really what it does. It's a catalyst, it's an energizer, it's short lived, but the consequence of it will go on hopefully for months and years. And then if we come back again, we can just give it a little bit of a turbocharge.
Yeah, I think Burnley is such a great case study. I've been to Burnley over the years, and as you said, for sort of a post-industrial space in an area that I think is traditionally thought of as maybe sometimes impoverished. The community feel at Burnley and some of the community assets in Burnley are just incredible, and I think the rest of the country can certainly learn from some of the activities they've done. I'm going to bring the question down to something a little specific and myopic, and then I'd like to finish up because I want to be mindful of your time. So we're talking about some big picture things, and this question I almost feel apologetic asking, but I'll ask it anyway because I want to know your take on it. I think that with some of the interventions, some of the programs we've talked about, we've seen that active travel and things like walking, cycling, getting around town seem to be programs that we can scale up really nicely. And they have a host of benefits in terms of social connection, helping people with diabetes, heart conditions, things like that. Um, but we just did a workshop 2 days ago, and the questions we kept on coming up from a lot of the older participants were about bone mineral density and strength training and things like that. And it occurs to me that we don't really have any opportunities that allow people the chance to engage in the sorts of activities that might help with bone mineral density or sarcopenia or dynapenia and all these things that are concerns with aging. So I was wondering, what are some potential programs or ideas that we can give people opportunities to engage in that sort of physical activity?
So I think a person I would always want to kind of go to is Samuel Gray. I'm not sure if you know about him, but for those who don't know him, he's an amazing kind of powerhouse of someone who's driven the whole agenda for older people. He himself is late 70s. He used to be very high up in the Department of Health and also as a surgeon before that. Um, and he says how desperately important it is to get that older community engaged. And that's where those conversations are so important, because there's a lot of fear and there's a lot of concern about becoming active as you become older. And particularly for those who haven't become, um, haven't caught up really with the activity, the sarcopenia goes so quickly, the loss of muscle and the osteoporosis. And we also know that we now know that emulsifiers in completely separate, but emulsifiers and ultra processed food strips away the calcium. So one of the main reasons why we're getting osteoporosis is the ultra processed food.
That's interesting because in John Snow, one of the earliest epidemiologists who's famous for his work on cholera, he also did quite a lot of work on food additives and vitamin D deficiency in bread. And I think that's one of the things that he actually found as one of the additives that was associated with vitamin D deficiency and rickets back in whatever it was, the 1860s. So it's something we've known, in some level, for well over 100 years. It's interesting that we're relearning that again.
That's interesting. I didn't know that at all. He managed to work that one out. So I think for older people, as we know, the importance of exercise exponentially goes up as you become older, but you can only do limited number of things. And the important thing is that active travel is not always a safe an option for someone in their very elderly, if they've particularly got osteoporosis. And the risk of falling if you haven't actually had much exercise has to be taken into account. We can't just tell everyone to just go out walking. If you look at the data, physical activity actually increases the number of falls in older people. So with walking, so if they're untrained and they're going out on their own and you don't do it suddenly, one has to be really cautious about it. And of course, confidence will go if they have a fall. That would be the end of it. So I think what we have to do is have that conversation with an older person, but make sure we've got as many organizations around that person, or it can be just family or the carer, that the carers know that they have to take that person out for a short walk all the time, and make sure they've got protection if they're particularly vulnerable. But I think the message has got to go through that despite the dangers, despite the fact it's hard work, despite the fact that it's out of their comfort zone, the activity levels in older people is so fundamental if to retain your independence and not to be a burden for your next generation. That's often what I do. I don't like make, it's not a kind of threat, but it's just to say, think about it for yourself, but also think about it for others, because I know that you love your grandchildren. You wouldn't want them to have to look after you when you can do it yourself. And there's an element, and the kind of one person I feel is a great bastion. People in the United States won't know of her at all, but Angela Rippon is 80, and she was on Strictly Come Dancing, and I've been working with her this last year, and she has absolutely kind of nailed the fact that at 80 you can still be incredibly flexible. She still goes up to London, she goes all around the country talking. She keeps herself fit a whole time, and she's disciplined, and she was a dancer. But you just know that it's I look around and I see people walking really slowly, and I feel we know that's a fantastic, unfortunately, in a wrong way, correlation to early death and everything else like that. If people are overtaking you in the street, you should therefore be thinking, I need to get much more active again. I need to start building it up. So the importance is there. The caution is there. It's the one time I would say we need to be a little bit cautious, but we have to have those exercises and things for other people to be around and enjoy the fun, even get the dancing, making sure that there's that infrastructure around for older people to have.
That's really good. I want to be mindful of your time, so I'd just like to ask you one more question, and then I'll let you go. Which is, what are some trends that have you feeling optimistic about the future? What are some programs, interventions, ideas, conversations? What has you feeling good about the direction we're moving in?
Well, I think there've been a big shift, I'd say, in the last 5, 10 years. I think some of that can be because nothing else is working and we're heading towards disaster for healthcare systems around the world. And something has to be done because we're already encroaching, whatever percentage of GDP spent on health, and that's just going to get bigger and bigger. So, that we're being forced to do something, and we're being forced to be told that the old system doesn't work. So I think that's been a good driving force. COVID, I think, really helped people understand about their local place, and people started to visit and go out to. I talking about nature when I set up a green gym back in the 1990s. I was a weirdo kind of doctor, tree hugging, crazy man. Now I'm actually, I don't even have to explain it anymore. It has come on so far, and our green social prescribing in this country is the world leader. We have now got it absolutely established, and it's we've got people from all around the world. One time we've done something quite good, I think. So I think the nature connection is really, really, really powerful. And I think also we've moved away from this physical activity being a kind of additive to try and sort out health, like the iron was for diabetes, for anemia. And we've much more moved now into people just having a better life and enjoying it. And that should be taken away from a healthcare system. NHS is not good at that kind of stuff. It should respect it. It should respect the communities doing it and the charities doing it. Even, dare I say it, there should be funding that goes to those places. But don't look down on them, and I'm saying to the NHS here, don't look down on them as though they're inferior to the amazing stuff that we do in the NHS, because they're providing the health, which will be the kind of foundation to stop the NHS falling apart. And I think there needs to be a mindset. And I'm just starting to see, I was in a conference about neighbourhood health, which hopefully will come in the 10-year plan for the NHS. If neighbourhood health really is what it says it is, it means the NHS starts to work with the communities, respecting them, building them up like never happened before. So I think there's some real positives. Climate change, I think we've got to be careful, because I think when we hitch it to that, people start to feel they're having to do something because they've been bad people. So I think we should push it back to just the joy of living, really, and that thriving.
I think that's a great place to end it. So, Dr. William Bird, thank you very much for your time. I really appreciate it.
Brilliant. Thanks, Andrew. I've absolutely loved it, and you've been fantastic in your questions.
Thank you.
It's a daily exercise. It's a daily exercise. It's a daily exercise.
Welcome back. I really enjoyed that conversation. I think I'm going to put that in my top 5 of our episodes so far. I really thought William's take on how health is created through connection, belonging, and feeling valued is that shift away from thinking about exercise as a prescription to seeing it as a natural outcome of a thriving community. And if you've ever gone through any of our reading lists or come on any of our courses, you know that that's really at the heart of everything that we do. One of the most powerful points he made was around chronic stress and how it changes how we function and kind of ramps up vigilance and can remove the desire to move. And it's just a reminder again that for many people the barriers to being active are absolutely not willpower or knowledge. They're about feeling unsafe or disconnected or undervalued in the places that we live in. They also talked about how you can reach those who need it the most, and it's not about sort of sweeping in with these exercise interventions which often just cater for those that are already active. It's more about starting where people are. And again, we've touched on that theme a lot recently, building trust and making that first step the easy and enjoyable step, the easiest choice basically. It's that public health adage of make the healthy choice the easy choice. And that's how you can kind of create community and an environment that makes movement the obvious choice. So thanks for listening to that. You can find all of the links to Beat the Street and other projects that William's been involved in the show notes. If you enjoyed the episode, please remember to subscribe. It makes a massive difference. We will be back in 2 weeks' time with Andrew talking to Matthew Remsky, who is a writer and a researcher and a co-host of the Conspirituality podcast. This is a really good episode. They talk about that crossover between wellness culture and conspiratorial thinking, how charismatic leadership works, and what happens when yoga and spirituality get mixed up with misinformation. It's a really, really good chat, and we'll see you back there for that one.